Thank you so much.
So, Dr. Nalini, will you start or shall I?
Yeah, I will just one or two lines we says normally speak. We don't go lengthy.
Yeah.
Introduce
Okay,
the
sir.
speaker and
Thank you
start.
so much. Thank you. Good night.
Only just to wait to the participant related to join.
So, sir, with all your permission, we are starting now. So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the organization assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event hosted by the National Neurology Forum. And the focus of today's session is role of point of care USG for neonatal cardiac assessment. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Nalini Kant sir to coordinate the further session today. Over to you, sir.
So, Naveen, Dr. Naveen, actually difficulty here. Previously, when we spoke in Zoom platform, we can see how many participants are there, how many trainees participated. So, Rituparna ji, anyway, can I know how many participants joined? Because we normally this is a training session for trainees and fellows. So wait for 50 participants to join. Unless we know, is start the session, the teaching session. Difficult to initiate from my side.
Okay, sir, just let me talk to my tech team. I will be getting back to you, sir, shortly. Hello, sir.
Yeah.
2 minutes back it was 45, but right now it's 33, sir. And it is keeping on fluctuating, sir. Already 45 people have joined to the online delegate portal.
Sir is consultant urologist and director of
Perfectly fine. It's just 30 plus joined also. You can probably initiate. Dr. Naveen, should we wait 1-2 minutes or we'll go ahead?
Whichever way you feel right. Whichever way.
Because there is no way to know actually how many, because previous platform, the faculties and the delegates, the number will display here. The live we know. So here we have to change the format probably. But it's fine.
So I think we can start, because people who have joined on time, at least they should get the They should get the privilege
So,
of.
so good evening all. Welcome to a new session of NOEL today. As all of you are aware, this is the 4th year of consecutive NOEL session. And this year we are now in the 19th session of NOEL teaching session. As you have seen in many of the sessions, after each 3 or 4 cases in a specific system like cardiovascular, neurology, nutrition, we will invite eminent faculty from the country who every time the eminent faculty who is specific interest in that subject. So they will guide us in after 3 or 4 case presentation. One session will be a teaching session from eminent faculties. That's we are following. So in the same sequence in cardiovascular, in the last 3 cases, we talked about the PDA in a preterm baby and its difficulties in managing and assessing the baby, and coarctation aorta, if babies, how the early detection saves life of a baby, newborn baby with coarctation aorta. And we saw a circulatory failure shock situation in a newborn baby, how to optimize the inotropes. With these 3 different situations and case discussions, what we learn in all the cases, probably the point of care ultrasound, the role, the ultrasound 2D co-assessment continuously non-invasive way, it helped in the managing the baby in many steps, many different situations. So to enhance our learning and understanding, today we have invited and we are privileged to get a eminent faculty, Dr. Naveen Prakash Gupta, who is very passionate teacher. You will see next few minutes when he will go for the session. He is very passionate in teaching, and his main area of interest is point of care ultrasound in all the organ assessment, the brain, the lungs, the heart, all the assessment. He is a master and he's teaching for last so many years in the trainees and students. And as an eminent faculty for neonatology, he joined across all the national conferences. He has a lot of publications in the teaching institution. He is chief neonatologist of Rainbow Children Hospital, New Delhi. As you must be aware, and probably people must be in this North Zone and the Delhi zones. He is a very active member of NNF. With this, probably we will invite him and we will try to learn from Dr. Naveen in the next few minutes how exactly a neonatology trainee bedside optimize the use of. I hope that in many of the tertiary care level hospitals, now bedside ultrasound is available. But how to optimize the use, so that a brief introduction primer this session will teach us and guide us in the what best way bedside we can use the session. With this introduction, I will invite and handing over the session to Dr. Naveen, and he will the presenter and lead discussion throughout the session. He will lead. In the meantime, end of the session, 5 or 10 minutes, we will take few of the questions from the delegates. So we'll try to clarify. Dr. Naveen and me both will try to clarify few of your questions. So throughout the session, please post your questions, because it's not allowed to directly to answer the questions. But in the meantime, you post your questions, so we'll take those questions in the later part of the session. Thank you, Dr. Naveen, for joining us, and please you can carry the session forward.
Yeah. Thank you, my dear friend Nalini. So at the outset, I would like to thank the NOEL coordinators, Dr. Nalini Kanta, and for inviting me to be here, being a part of you, and the way the NOEL is going on in the last 4 years, it has been amazing. Thank you for the kind introduction. And now I come back to the topic. Am I audible clearly, Dr. Nalini? Am I audible?
Perfectly.
Yeah.
Perfect.
Okay. So yeah, I will just share my screen and just let me know that if my presentation is visible nicely. Just 1 minute. Is my presentation visible? Slides visible?
Completely. It is clearly visible.
Okay. Right. So, today's topic is the role of point of care ultrasound for neonatal cardiac assessment. It's quite a lengthy topic, but I would like to touch, or I will try my best to touch upon the key areas or key points which are of use for a neonatologist while managing any baby who needs the cardiac assessment. So how we will do is we will spend some time on the basics, some time on the calculations and the views, and then we will try to look into the clinical applications. As Dr. Nalini suggested, how can we make use of this point of care sonogram in assessing a baby with PDA or the PPHN, or when the child presents to us with the shock. So whenever we talk about the basics of echocardiography, there are few views. One is the 2D mode, and 2D mode is basically, it's the mode where the images, they are black and white. So whenever you see any structure, whenever you want to see, heart is a structure. If I want to see 4 chambers and the 4 chambers, they appear in black and white, that is the 2D mode. Now, in the heart, the blood is flowing. So in ultrasound, when the fluid is flowing, if you put the color mode, you can assess the direction of flow of the blood. So in color mode, the synonymic is BART. What does BART means? If you look at the blue, if the color of the flow is blue, that means that the direction of flow is away from the probe. So suppose, let's say I assume and I make this 4-chamber view of the heart and my probe is lying here. Just interrupting for 1 second, Dr. Nalini, is whatever I am drawing, is it visible on the screen?
Clearly visible. Is clearly visible.
Clearly visible. Right.
Yeah.
Sure. Thank you. So my probe is lying here, and if suppose I put the color mode on and I see whatever blood is coming here, because it is coming towards the probe, so this will be red. BART means the blue is away and red is towards. So this will be colored as red. Now, suppose in this chamber, the blood is going in this direction. So then, because this blood is going away, so that will be seen reflected as a blue. So blue does not denote the venous and red does not denote the arterial blood. So it denotes the direction of the flow of the blood, or in other cases, the fluid which is toward the probe or away from the probe, right? So this is the color mode. Now, if I want to assess that with what velocity this blood is moving, whether it is moving away or it is moving towards, that velocity I can assess with the help of the Doppler. So Dopplers are of 2 types, color Doppler and tissue Doppler. For today's discussion, let's stay away from the tissue Doppler. So color Doppler will tell me that, okay, what is the direction of flow of my blood, whether it can be away or it can be towards. Now, there are 2 kinds of color Doppler which you will encounter. One is pulse wave Doppler, one is continuous wave Doppler. Broadly speaking, the difference between the two, the continuous wave Doppler is for high velocity flow. And the pulse wave Doppler is for the, is when we have to, if I have to measure the flow at a particular point. Suppose, let's say, so suppose I want to assess that suppose the blood is going like this. So if it's a very high velocity flow, then I will use the continuous wave Doppler. Normally the cutoff is taken as 2 meters per second. Now, if it's a low velocity flow and I want to measure the blood at a particular point, suppose I want to measure what is the velocity of blood here. So flow is like this. So velocity can be measured here, here, and here. So suppose I want to measure a velocity at a particular point, then I will use the pulse wave Doppler and the velocity should be low. And if I want to measure the velocity across the line, there is no particular point, but it is across the line, then I will use the continuous wave Doppler. Practically, in NICU, when you are assessing a newborn for the function assessment, the only tricuspid regurgitation is the area where the velocity is very high, and that is the place where you will use the continuous wave Doppler. Otherwise, for all the measurements, you will use pulse wave Doppler. We will be seeing these measurements in the presentation. Then there is a M mode also. What does M mode means? M mode means that if you want to, in cardiac assessment, it's very, very important to assess the dimensions of the chambers. So what does M mode means? M mode means that, like, if my ventricle, I will draw something like this, and this is a right ventricle and this is a left ventricle. Now, if I want to see that how my, because LV is contracting and dilating, so how the ventricular dimension is changing. So then I will put M mode. In M mode, on the x-axis is the time, and then you can see the chamber or you can see anything which is moving against the time. So suppose LV is coming like this. So that means this is the dimension of the LV in diastole and this is dimension of LV in systole. So something, if you want to measure that the changes in the movement, changes in the dimension of the structure across the time, then you would like to use the M mode. So with these basics, let's come directly to the what are the normal views. So whenever you want to do the echocardiography, there are various kind of the probes which you will see in your ultrasound machine. Phased array or sector probe is the one which is being used for doing the echocardiography. The curvilinear is the one which you can use for abdomen or for the ultrasound cranium, and linear probe is the one which you use for the vascular structure. Why is it so? Because these probes, their frequency is different. Frequency is different. Now, what does frequency means? If you are carrying a probe with a higher frequency, that means higher frequency means resolution is very good. Very good. That means you will get a very, very nice picture, but the depth of penetration of ultrasound wave is very less. Depth is very less. So higher the frequency, depth is less. Other way is the other. So lower the frequency, the depth is more. Okay. So for sector probe, there can be different probe. Let's assume that if you have to scan an adult heart, because adult heart, the distance from the skin to the heart is more, so you will use a low frequency probe. A term baby heart, you will use a higher frequency probe rather than the adult heart, maybe suppose 5 or 6 or 7. For adult, it may be 2 hertz, right? And for a preterm baby, it may be slightly higher. So a phased array probe is used, and so sector probe is used. So this should be clear. Second is, whenever you are putting the probe, there are few movements of the probe which you should be knowing. So suppose this is the probe. Now, probe rotation means you are rotating the probe. Probe sweep means you are changing. Suppose this is the chest of the baby. Now you have put the probe initially here. Now you move it here. So that means you are sweeping the probe. Now tilt means I cannot demonstrate you, but when you are tilting the probe along the long axis. So tilting is across this segment and angulation is at this point. So tilting means it's difficult to demonstrate on the Zoom, but suppose if you imagine the heart is lying in the body in a three-dimensional picture, and you tend to align your probe towards the direction of the heart. Suppose I say that, okay, heart is lying in the body like this, and your probe is like this. You will try to tilt it anteriorly to bring the probe in the direction of the heart. That is called tilting, right? Sweep is when you are sweeping it. So orientation of the heart is very important. Heart is lying in the body like this. There is two axes. This one is the long axis. This one is the short axis. And if your probe is here, you will slice the heart along the chambers. So one is the long axis and one is the short axis. So I'm going little bit faster because unless and until otherwise I will not be able to finish the presentation, but I will try. You can put your questions in the chat box and just try to understand the concept. So whenever we talk about the apical view, that means my probe is lying here at the apex and I'm trying to open up the heart. I'm trying to open up the chambers of the heart, and then with little bit of angulation, I will try to visualize two vessels. One vessel, this is the pulmonary artery and this is the aorta. You see which vessel is anterior? Pulmonary artery is anterior to aorta. Remember this. Right? In the diagram you can see. Fine. Now, this is the LA, okay? And these are the pulmonary veins. Now, if suppose you want to cut the heart along the long axis, then what will happen? So remember that the anterior chamber is the right ventricle and the posterior one is the left ventricle, and the posterior most becomes the LA. And when you slice the heart along the short axis. So we'll see that. Now the views are, normally in NICU, we usually start with the apical view, although some people start with the parasternal view also. So apical means your probe is pointing at the apex. Parasternal means probe is pointing in the parasternal area. If the direction is toward this is called long axis. Why long axis? Because heart is lying like this and you are cutting the heart along the long axis. And short axis is this. So if the direction of the probe pointer is toward this, that means short axis, right? And this is the apical. Now, if you want to scan everything through the subcostal region, you can scan. And this IVC, we will come to know that how the subcostal view IVC can be taken. So basically, these are the views. And we understand that if the heart is lying like this, the upper structures, like suppose you want to see the arch of aorta. Suppose you had a coarctation case which was discussed last time. So you will go through the suprasternal view. And this high parasternal, the ductal view or the high parasternal view are slightly above the parasternal views. Okay. Now let's come to the apical four-chamber view, where your probe is at the apex. So just below the nipple, And every probe has got a pointer. Remember, that pointer is very, very important. So that pointer is also displayed on the screen. So normally in apical four-chamber view, your pointer is at 3 o'clock position. So remember, you draw a clock like this. This is 12, this is 3, this is 6, and this is 9. Okay. Now pointer is at 3 o'clock position, right? And then in your picture, when the pointer is here, that means because this is left side of the baby, this is left, this is right. So this is left. So that means the pointer is here. So that means the chamber which is the LV. Suppose there is a mismatch. Your probe pointer is here, but on the screen, the pointer is lying here. Then the things will get inverted. So always remember that wherever your probe pointer is, see the pointer on the screen also. Now, through the apex, when you put the probe, you will try to see this kind of a picture in which 4 chambers are seen. The chambers on the left side, bigger one is LV, this one RV, RA, and LA, right? Not a difficult view. The clue is that your apex should be in the center of the screen. Okay. So like this one, you can see that the 4 chambers very nicely. You can see that this is the LV, this is RV, this is RA, and this is LA. This valve, this is the tricuspid valve, and this valve is the mitral valve. Now, this is the apical 4-chamber view. Why it is being used for? Very nicely, you can see that the chambers are how filled they are. So this is an image in which the chambers are nicely filled. If suppose the chambers are very poorly filled, this wall and this wall of the ventricle, they will be opposing each other, and that is called the kissing ventricle sign. So a very nice assessment can be done of the chamber filling can be done in the 4-chamber view. Contractility, just by visual eyeballing, you will call a cardiologist to do the echo, and you will say that, oh, in the first view, he will say that the cardiac contractility is this much. Rather, he will give you an estimate of the fractional shortening because he is doing echoes day in, day out. So that's why he know that, right? So this view is very, very important. So this view gives hell lot of an information. Now, with apical 4-chamber view, there is an apical 5-chamber view also. What is 5-chamber view? Which is the 5th chamber? 5th chamber is the aorta. How do you open the aorta? You tilt the probe little anteriorly because aorta lies anterior to this, and then you will open the vessel which goes like this. So now can you see? Now this was LV, this is RV, and this vessel is the aorta. Okay, this is LA and this is RA. So you can see now what is the information you can get? So in newborn, if you want to see what is the left ventricular output means what is if the blood is going in this direction, if you want to assess that in each stroke how much the blood is going, and in 1 minute ml per kilo per minute how much is the volume going, so that these things have been validated, so that can be assessed in this view. So apical 5-chamber view. So apical 4-chamber and 5-chamber, and then many people, I will show you the video in some other like in the later part of the presentation. But if you tilt the probe little more anteriorly and along with that rotate it clockwise, you will see the 6th chamber, which is the pulmonary artery, which is arising from the RV. I will show you later. Now coming to the parasternal long axis view. Your probe is lying in the line joining between the two nipples. The probe is there and the pointer is pointing towards the right shoulder. Okay. And then you are slicing the heart in this direction. Your probe is like here. Okay. So because you want to see the place where the vessels are arising. So if suppose along the long axis your probe is here, then you will just see two ventricles only. The purpose of parasternal long axis is you want to place the probe where the aorta is opening. So in parasternal long axis view, your intention is to see the LV outlet and LV inlet. We will see this. So when you are cutting the heart along the long axis, which are the structures you will see from anterior to posterior? First is you will see the right ventricle. It is the anterior most chamber. Then you will see the LV. But you are not seeing the apex. Apex will be somewhere here. Okay. Now you see the left ventricular outflow. What is outflow? Aorta. So aorta, see, it is horizontal here. And aorta is lying against the posterior most chamber, which is the LA. So again, going from anterior to posterior, the RV, the LV outlet, which is aorta, and LV inlet, which is LA. And these two, they are the mitral valve. Okay. So we will look about the clinical application of this thing. Now, in parasternal long axis view, we have seen the LV outlet and LV inlet, but we have not seen the RV outlet and RV inlet. So for that, we will do the sweep. What is the sweep is wherever my probe is, if I do a superolateral tilt, if I tilt it superiorly, then what will happen is I will open the this is the RV, sorry, this is the standard view. This is the standard view. Let's move ahead. So yeah, so this is the inferior tilt. I will come to this. Okay. So if I do the superolateral tilt, superolateral means my probe is lying like this, and then I am tilting it superiorly. So this is the superolateral tilt. Where my probe is placed like this. This pointer is towards the right shoulder only, but I am tilting it. So then when I am tilting it, what I am seeing is, can you see this valve? And can you see this vessel? This vessel is the pulmonary artery. This is the RV outlet and RV small, and this is the pulmonary valve. So why this view is very important is because you are seeing the RV outlet, and here, if you want to assess the right ventricular output, this is a very, very good view because the flow is parallel. I forget to tell you about principle of Doppler. Doppler estimates flow the best if flow is parallel. I'm going very, very slow because it's 8:26 and I have to finish the presentation by 8:50 and the presentation is very long. Okay, no problem. So this is the superolateral tilt. And if I go inferiolateral means my probe is lying like this and I am tilting it inferiorly towards the pelvis. If I do that, what I will see is I will open the RV inlet. So this is RV and this is RA and this is the tricuspid valve. Okay, so this is the parasternal long axis view. Now, in the same position, in the same place, what you will do is, so in the same place, what we will do is, previously our probe was lying like this and pointer was towards the right shoulder. Now I rotate it 90 degrees. This is same, but the pointer is now placing toward the left shoulder. So then I am cutting the heart across the short axis. And then this characteristic pictures come. In the short axis, when I am cutting the heart, what I will see is that this is the RV, this is the pulmonary valve, this is pulmonary artery. This pulmonary artery is encircling aorta. This is left atrium. There is the interatrial septum. And this is the right atrium. And this is the tricuspid valve. So parasternal short axis view is when I am cutting the heart across the short axis and provided I am cutting it at the place where the aorta is arising. Now there is a very nice parasternal short axis view tilt when I'm tilting my probe towards the apex. And when I tilt it towards the apex, what happens is, first I will see, then I will lose the vessels and I will see the right ventricle and the left ventricle. First, I will be cutting it at the level of the mitral valve. So this is the mitral valve. This is the place where the fractional shortening is assessed. And then I go a little further down. And when I go a little further down, you can see that I am seeing these papillary muscles. And if I go further down, what I will be seeing the apex. So basically, so these were the view. Ductal view is little bit higher than the parasternal short axis view. My pointer is pointing little bit, it's like left shoulder, but little bit in the, you can say 11 o'clock position. And then I have to tilt it slightly towards the left side. And there I will see this 3 vessel crop thing. Let me see. Okay, yeah. So this is the pulmonary artery. I will stop. Okay. So this first vessel is which is lying, this is aorta, which is lying alongside aorta is the RPA. The second vessel is the LPA. And this third vessel is the duct, PDA. Now, usually when it's a preterm baby, it's very easy to identify because when you put the color mode, you will see that the color is red. Okay. And in these 2 vessels, because the blood is going in this direction, so this is blue, and this is going like this, so this is red. Sorry, I'm not changing the pencil colors because the time is short. Okay. So like the way you see something here. So 3 vessels, and then you can see that this is the plain laminar red flow, and this is the duct. Okay. Now, high parasternal view, for the time being, let's leave it. Now, suprasternal view, you will see the arch, and this one is the right pulmonary artery, and this corresponds to the carina when you want to see the tip of the endotracheal tube. Anyhow, this is the aorta, and these are the 3 vessels which are arising from the aorta, right? You can see in this video. So this is the RPA, this is the arch, and I cannot see the 3 vessels, but they will be arising somewhere here. Okay. I think for the time being, this thing about the subcostal view, let's leave it. So what's important is now I will come to the second part of the presentation. And in that, I will be again discussing about the view. Part 2 is calculations. Why are we doing these views? So most important thing. So let's go one by one. Okay. Okay. So when I discuss about that, why are we doing this view? We start with the apical view. In apical view, I tell you what information you can get. When you are with 4 chambers, you can see that, okay, how well my chambers are filled. You can see the contractility, although this is subjective view of the contractility. Okay. Now, if you want to measure it objectively, then you can measure in the 5 chamber view, you can measure the LVO. We will see how do we measure it. Then suppose you are dealing with a case of PPHN, then you can see that tricuspid regurgitation. What does it mean? We will see. And also TAPSE. Let's see. So this is okay. So concentrate on this video. This video goes from apical 4 chamber view to 5 chamber to 6 chamber view. Okay. Right now you are seeing 4 chambers, RA, LA, LV, and RB. Okay. So right now you are seeing these 4 chambers. Now this one is the aorta, 5th chamber. You see aorta is arising from the LA. Now if I tilt my probe more anteriorly, can you see a vessel which is, a vessel which is arising? Now, can you see a vessel which is arising from here? And this is arising from the RV, and this vessel is the pulmonary artery. So that's how, with the apical view, you can see all of this. Now, our purpose is 5 chamber. In 5 chamber, this is the aorta, and there the valve is there. So I put my pulse Doppler. Okay. I forget to tell you about the 3 principles. One mode was the 2D mode. Remember, 2D mode was for black and white. One was color to assess the direction of flow. Third was Doppler. And Doppler was to measure the velocity of flow. Now, the principle is 2D structures are seen if the structure is perpendicular to the beam. And in Doppler, you can measure the velocity best if flow is parallel to the beam. Suppose this iota, I want to measure the flow, and my direction of the pulse wave Doppler is like this. Okay. So let's assume the direction of pulse wave Doppler is this. Let's say that my blood is going in this direction. So you see the angle is there. This angle will be very less, 10-15 degree. No problem. If let's assume that the direction of the flow is like this, and my pulse wave Doppler is like this. So then the angle is very huge. The bigger the angle, we will underestimate the flow. Remember that you can never overestimate, but you will always underestimate. So this angle is called angle of insonation, and 30 degree is acceptable. But try to align the beam of your pulse wave Doppler along with the beam of the flow. The more you can align, like you need to put your view in such a way so that the beam of the pulse wave Doppler is parallel to the beam of the flow. Okay. So then you can assess the output. So what you will do is you will put the how pulse wave Doppler, right? Why pulse wave Doppler? Because I want to measure the thing here. This is called the range gate. It's not a continuous wave Doppler. CW is used only in TR practically. If cardiologists will use in many other stenotic lesion, etc., where the velocity is very high. Then you will see this kind of a picture. You can see centimeter per second here. In this picture, the x-axis is time, the y-axis is velocity, and you see that this kind of a waveform is being made. Remember that this waveform, the central area should be black, and this periphery should be white, and this is called envelope-like picture, halo. If this is not there, then either your flow is turbulent or your alignment is not right. Okay. So this should be there. Then there is a thing by which you measure the velocity time integral. Y-axis is velocity, x-axis is time. The area under the curve of waveform is called VTI, velocity time integral. If I put just my probe pointer at here, they will tell me the velocity. Okay. So velocity time integral, suppose in this case it is 14 centimeter. So velocity time integrals tell me roughly about the stroke volume. In one beat, the heart is pumping how much blood. Now my aim is to calculate LVO, and LVO is calculated in ml per kilo per minute. There is a formula for it. This lecture does not allow me to give formula, but I have to calculate the area, which is the pi d square by 4, And for this, I want to know the aortic root diameter. I should have a VTI, and I should have the heart rate, and I should have the weight. This tell me in one stroke volume how much is going on. If I multiply this by the heart rate, then in 1 minute how much is going on. If I take area into account, that means in how much area this is going on. And if I divide it by weight, then it comes as ml per kilo per minute. The formula is very, very simple. LVO is equal to VTI multiplied by area multiplied by heart rate divided by weight. This is ml per kilo per minute. So why do we want to calculate LVO? Because normally it is 150 to 300 ml per kilo per minute. Suppose a baby comes to you and it is 40. You give volume, you start the baby on some inotrope, adrenaline or whichever, and you see the improvement in 80 to 90. You will say that, oh, it's working. So LVO is an objective parameter. Another thing in the 4-chamber view you can see is the tricuspid regurgitation, which normally we see when the baby is having PPHN. What is happening in PPHN is, this is your 4-chamber view. Now, the blood from the RV, it cannot go into the pulmonary artery because the PA pressure is high. When the PA pressure is high, the blood goes back from the RV into the RA. Now, if I put my continuous wave Doppler, because the velocity is very high, so I will put the continuous wave Doppler, and I cannot tell you, but see, in continuous wave Doppler, our line is there and it measures the flow across the line. And then you see this kind of a waveform. You don't need to measure the area. You just put the pointer here, and this will tell you what is the velocity, what is the pressure difference. This pressure difference, PG max of 39.5, is between the two chambers. This is RA and this is RV. So RV minus RA is equal to 39.5. And RA normally pressure is 5 to 10. So if I add that, I can get the RVSP, that is right ventricular systolic pressure. Here the machine is calculating on its own that the right ventricular systolic pressure is 44.5. Okay. So this is how this gets a very, very nice correlation in the cardiac catheterization study along with the pulmonary artery systolic pressure. And higher it is, we understand that bad it is. TAPSE for this presentation, we leave it. EA by IVRT, we leave it. So what I wanted to tell is that everything has got, every view will be some bit of informative to us. Like if you want to assess volume, how can you assess volume? In adults, we assess volume by inferior vena cava in the subcostal longitudinal view. In the normal babies also we can do. What you will do is, suppose this is the chest, this is the xiphisternum. You will put the probe like this. Your marker is at 12 o'clock position, and because the IVC is right, you will do a right tilt, little bit of right tilt, and you will open the inferior vena cava. We will see the picture. So this is the inferior vena cava. This is the inferior vena cava. And what it is entering into, this is the right atrium. And you see this is the hepatic vein. And here we cannot see, but in day 1, you can see the ductus venosus also here. So by measuring the diameter of the inferior vena cava, you can see the volume. And there is one parameter which is collapsibility index, which can tell you whether your IVC is fluid responsive or not. What does it mean? The diameter of the inferior vena cava changes with the phases of expiration. In inspiration, the diameter will be lesser. In expiration, the diameter is more. So you see the difference, and you can calculate the collapsibility index. Like here, you don't see that this is the inferior vena cava, this is the RA, and you don't see that it is changing along with the phases of respiration. So what you do is you put the M mode. This is the M mode. Remember M mode, the function was that x-axis is time and this is the structure. This structure is inferior vena cava, and you want to see the volume. One is this volume and one is this, sorry, you want to see the diameter. One is this diameter, one is this diameter. So this is 0.35, which is during expiration, 0.30 is during inspiration. You say 0.35 minus 0.30 divided by 0.35. And what do you find? That it is 14%. So normally, if it is less than 15%, you will not give volume. If it is more, that means that it's a collapsible IVC and you can give volume. Another thing you can, in myocardial dysfunction, you can see about is the contractility by visual estimation. You can see that this is a good contractility. And look at the chambers here. This is just a flicker. This is such a bad contractility. So that means, and the chambers, they are adequately filled. So that means this baby needs inotropes. This baby does not need a volume, right? So many a times this point of care sonogram can tell you about a lot of things. For the purpose of this talk, I am leaving about the superior vena cava flow because this will become a little bit too much. Now, I think we are not too delayed on time. I might be a little bit faster. So now what are the clinical applications? So in neonatology, where all we can use it, one is in PDA, one is in PPHN, then shock, and then if you want to assess any organ perfusion, because we understand that with the help of pulse wave Doppler, in individual vessels, like if you want to assess the intestinal perfusion, the SMA and the celiac axis, they are very easy to identify on the subcostal view. So you can assess that. Similarly, the middle cerebral artery is very easy to identify in the ultrasound cranium. So these things can be done. So let's go one by one. Let's talk about the PPHN. Assessment of HSPDA. Okay, so because it's already 8:45, so we will spend 3 to 4 minutes in each illness. So important is you should understand that what are the circulation changes happening in PDA. So in this schematic diagram, this is RA, LA, RV, LV. So what is happening is that the blood which is going from LV, in spite of all of this going from here, the blood is being diverted through the duct into the pulmonary circulation. And pulmonary is also getting blood from RV. So the lungs, they are being flooded. Now more blood goes to lung, more will come towards the LA. If more blood comes to LA, LA will start dilating. And it goes to LV, more blood, LV will also start dilating. If the LV function is good, then more blood is coming to LA, LV, more blood is coming, then left ventricular output will increase. Although the whole left ventricular output which increase, the blood is not going to the systemic circulation because a significant amount is diverting here. So there will be systemic hypoperfusion. That means that the vessels which arise below this will have lesser blood, like the superior mesenteric artery, like the celiac artery, like the renal artery. If you want to assess the blood there is a steal. There is a systemic steal which is happening. So these kind of things you can see on the echo. So if I say that, okay. So if I say that, so enlargement of the LA leading to increase in LAO ratio, enlargement of the left ventricle. Okay, so this LAO is very important. So when we say that the LA has increased in diameter and the aorta diameter is fixed. So there is a very nice in the parasternal long axis view with the help of M mode, you can assess the LA is to AO ratio. The higher the ratio, more significant shunting is happening across the ductus. Increase in the LVO, we have already discussed. Decreased flow in the descending aorta. Okay. So this is the parasternal long axis view. Just for the revision, the anteriormost chamber is the RV. This was LV. This is the LV inflow. This is the mitral valve. This is LA. And this is aorta. Can you see the aortic valve here? Okay. So now, if you assess that this is the size of aorta and this is the size of LA, it is more than double the size. So normally LA is to AO is 1:1. More than 1.2:1 is considered a significant ductus. More than 1.5:1 is moderate. and more than 2:1 is very severe. So you put the M mode, and in the M mode again the chambers will be RB, and this is iota and this is LA. So you can take the diameter of the iota, take the diameter of the LA. Both the diameters are here and the ratio is 2.67. So if the ratio is 2.67, that means there is a significant amount of shunting which is happening, because of which the LA has grown too much. Now, again, there is a ductal cut. So where was the ductal cut? Ductal cut was above the parasternal short axis view. In ductal cut, if you see, normally it should be 3 leg, although I am not seeing this vessel, but this is this dot which I am putting it right now. This is the LPA and this is the duct. Can you see how nicely even you can see the duct in the 2D view? The art, I tell you, is if you can locate the duct very nicely in the 2D view. So even in the 2D view, even in this view, you see that how nicely you can calculate the diameter of the LPA and the duct. Just by visual estimation, you can say that the duct is 1.5 times more than the LPA. Many people, based on the diameter, they say that, okay, which duct is significant if it is bigger than the LPA. Some people say it by diameter more than 2 millimeters. Some people say more than 1.6 mm. Although diameter alone is not a good thing. Now, this blue flow is of the LPA. Why blue? Because this is going like this. This blue flow is of the iota. And this one, the red one, is the duct. Now you see the red color. This is the laminar red color. Sometimes it is orangish. If it is orangish, it's a turbulent color. It's a turbulent duct. With turbulent flow means that the duct is closing. So I think this should be very, very clear that the ductal flow, okay, and then you can measure the diameter. You can see that you can measure the diameter here also, here also, here also. So always measure the diameter at the site of the insertion. And don't measure the diameter in the color mode. In the color mode, you may overestimate. I don't have time, but I have shown here that the same duct, the diameter is measured in 5 different places, and you can overestimate as high as 3.8 millimeter of a duct, which actually is 2.5 millimeters. And if you are treating it on the basis of the diameter, then you may have treated it. Okay. Then there is a flow pattern across the duct. I don't have time to explain, but this pattern, this kind of a pattern is called the pulsatile pattern. And the pulsatile pattern demonstrates that the duct is a significant duct. This is a restrictive pattern. Restrictive pattern is the high velocity pattern. So I think this I have just demonstrating you. This is a big duct, and if after treatment, see how small the duct has remained, how small. And this is the flow pattern, like the pulsatile flow. And look at the velocity, it is less than 1. 1 means 100, 1 meter per second, or some machine, it will be 100 centimeter per second. So less than 1. And after treatment, see it has become restrictive, and the velocity is 3, which is the 300 centimeter per second. So if it's a smaller duct, the higher the velocity, and it's a restricted duct. So what do you want to see when you are doing the echocardiography for PDA? Is my ductus patent? How much wide it is? Is there significant left to right shunting, which you can see by LA/AO ratio? And there are other parameters also, significant systemic steal and the flow across the ductus. Now, I don't know whether I have time or not to cover the PPHN in 2 minutes. Just I will try to tell you about the circulation changes. So in PPHN, the problem is that this RV is unable to push blood here because the pressure here is more. When the pressure here is more, the blood goes back. And this is being demonstrated as the tricuspid regurgitation. And when it goes back, this segment starts dilating and the septum starts deviating towards the left side. Similarly, when RA is bigger, there is a PFO here and the blood starts going in this direction from right to left shunting. And if I talk about the PDA here, because the blood can't go here, from the RV it is going in this direction. So in the PDA also there is a right to left shunting. So this right to left shunting, this blood going this direction, this going in this direction, and this going in this direction. And the septum is deviated in the apical four chamber view. You can see that the septum is deviated. So that's what is happening in PPHN. And there are methods, but the easiest is in the apical four chamber view, you put the color mode, and in the color mode, you can see this blue jet. Now in this blue jet, when you are seeing, so that signifies the tricuspid regurgitation. Now, how fast is it, and what is the pressure difference between this RV and the RA? How you can assess is by the use of the continuous wave Doppler. You put the continuous wave Doppler and you see this kind of a waveform, and you put the pressure, this thing here, and the pressure is estimated as 43.39. And you add 5 to it, and this is 49, and this is the right ventricle systolic pressure. So that's what you would like to see in the apical view contractility, because in PPHN, it's a state of diastolic dysfunction. Eventually, all the chambers of the heart, the contractility becomes poor. The tricuspid regurgitation jet, which can help you in estimating the right ventricle systolic pressure. The septum is deviated towards the left side, dilated RA and RV. LVO eventually decreases. And for today's class, I am not touching upon EA wave and IVRT. So I think in summary, if in PPHN you see a dilated RA-RV, the tricuspid regurgitation, EA you can leave, this I also didn't touch, and across the duct, it's a bidirectional or predominantly right to left shunting. Now the last slide of the presentation is in the shock. When the child is in shock, your dilemma is whether you should give fluid. I don't know why my... Okay, so the dilemma is whether you should give the fluid or you should start the baby on inotropes. Now, in a apical four chamber view, you can assess the filling. You look in the subcostal view, the diameter of inferior vena cava and collapsibility index. Then you can say that, okay, the fluid is bad or the fluid is more. Remember, the diameter of IVC alone is not a good parameter, because many a time the baby in shock is sick and he is on ventilator, and either on conventional ventilation you are giving high positive and expiratory pressure, or on HFO you are giving high mean airway pressure, which may make the inferior vena cava appear falsely dilated. So then the collapsibility index is definitely a good thing. And in the apical four chamber view, you can visual estimation you can do. Then the cardiac contractility. In the four chamber view, you can assess subjectively. You can objectively assess the left ventricular output. You can objectively assess the right ventricular output. Fractional shortening and ejection fraction can be seen, which today I did not discuss, but very easy to do. And then whether the heart is in diastolic dysfunction, you can check by EA wave and isovolumetric relaxation time, which will take difficult time to explain. Thank you very much. And I think I was quite fast today, but this was mainly for sensitization, and I shall be very, very happy to take the questions.
Thank you, Dr. Naveen. With the time of such a short time, such a topic, which is an extensive topic of assessment of different clinical scenario, and compiling everything into 45 minutes to 50 minutes is really difficult. But I thought the message is clear here. This is the sensitization that there is a machine tool available like a stetho in your NICU. And whenever there is a doubt, dilemmas of how to manage optimally with the other clinical parameters, keeping the parameters there. The other clinical parameters are there definitely to guide. But by adding this value, this ultrasound examination definitely adds values to the diagnosis and managing the baby in the difficult scenario. The way you highlighted, if a shock state comes, if I don't know, there's a low blood pressure or normal blood pressure circulatory failure possible, but I don't know fluid, I will challenge the fluid or I will optimize my inotrope or bus pressures. But this is the best tool to use and get a guidance. So in many places, in PDA also the dilemma is clearly highlighted here. Which parameters, not only the size of the duct, but other functional parameters, how helps us in managing. So I thought this message is very, very clear in all the three important clinical scenarios. And the job, your job probably I thought is well done with this stipulated time. Clearly the message given to the trainees and audiences. I hope a few of the questions we can take either directly if question comes, we will take. And I will request before going to question, I will request again taking 1 minute because we have time, 9:15 we continue. So again, if I'm going as a clinician or a trainee going bedside assessing PDA, so what are the views I will keep in my mind and in which view, particularly view proposition, what finding I will look for in PDA, in PPHN, and particularly in the low intravascular volume state. In three conditions, the views and its important findings. If just you can say again once to summarize, then we'll try to take the questions. In detail, it is discussed. Again, I'm saying, according to clinical scenario, which view, what findings I'm interested to look for.
Very nice. Right. So, so thanks, Nalini. Is my screen visible?
Okay.
Yeah. So if I have to assess for the PDA, the first view, when I look for the apical four-chamber view, I will see that because in PDA, the left side is dilated, so my septum is deviated towards the right side. I will see that my LA is enlarged too much. Okay, so in the four-chamber view, I will see this kind of a picture. In the five-chamber view, I will try to evaluate for the left ventricular output and I will see that this is increased. I move to parasternal long axis view and I assess the LA is to AO ratio there. And LA is to AO ratio is increased. I move higher for the ductal view, and in the ductal view, I can assess that what is the diameter of the duct. Then I can assess that what is the type of color. Is it a laminar flow, which is reddish, or it's a turbulent one? Turbulent is the orange flow. Then I can look at the flow pattern. So somebody very rightly right now asked in the chat box also that where should the pulse Doppler be placed? So if this is my pulmonary artery and in the three-leg view, these are the three vessels which are arising. This is duct, this is RPA, and this is LPA. Then I will put the range gate of the pulse Doppler here to assess the ductal flow. And if I see that there is a pulsatile kind of a low velocity flow, that means my duct is significant. Now, moving higher, I have to delete little bit of a portion. So moving higher, what I will go is, I will go in the suprasternal view. In the suprasternal view, this is the arch and this is the descending aorta. So usually the aortic portion of the duct is rising from here. This is the duct. So I will again look for my flows in the descending aorta here after the duct has arisen, because I want to see whether there is a systemic steal or not. So I will assess the flows here. And when I assess the flows here, what I will see is this kind of a waveform. So this is systolic flow and then this is diastolic flow. So in duct, if the duct is significant, this diastolic flow comes like this. So this is the retrograde diastolic flow in descending aorta. And then I will do the end organ estimation. I will look for flows in the celiac or the SMA if they are absent or reverse in the diastole. And I will look for the flows in the brain, that is the medial cerebral artery flow. So this is how I will complete my ductal evaluation. Now, PPHN evaluation is little bit higher. So in 2 minutes, I will try to cover that. In PPHN, apical four-chamber view, I will look for the contractility of the heart. then I will say that in this, because the RV is dilated, the septum is deviated towards the left side. Then I look for the color mode and I look whether the tricuspid regurgitation is there. Interesting thing is, PPHN eventually evolves into biventricular dysfunction, and MR is also there if you look for it. So TR, and I estimate the right ventricular systolic pressure with the help of the continuous wave Doppler. In the 5-chamber view, I will look for the left ventricular output, and there is a high probability that it is decreased, because in India, when we see these PPHN cases, the baby comes with PPHN and shock, and the LVO is also very much decreased. Then in the pulmonary artery view, which is the parasternal long axis view, superior tilt, where I want to see the pulmonary artery, there I can assess the right ventricular output also, and there I can look for the time also, the total time, which is the right ventricular ejection time and the time to peak velocity, this ratio. And then E by A and IVRT, which are suggestive of the diastolic dysfunction of heart, they becomes very important in the PPHN. Then I come to the ductal view, and in the ductal view, I see the bidirectional shunting. See, when we were thinking about the baby who is a preterm baby with PDA, there was a pure left to right shunting. Now in PPHN, there is either a bidirectional shunting or a predominant right to left shunting. I would like to say here that even with very high pressures in PPHN, usually it's a bidirectional shunting, because in both phases, that is systole and diastole, it's not possible that the pulmonary artery pressures will exceed the aortic pressure. If you see a pure right to left shunting, always suspect the cyanotic CHT, because usually those are the duct dependent circulations. So this is in general when you look for the PPHN. Now in shock, you would like to try to estimate the preload, and preload is with the help of IVC diameter, IVC collapsibility index, by visual eyeballing of the 4 chambers, and then you can assess the myocardial contractility in the apical 5-chamber view by looking at the left ventricular output. In parasternal long axis view, you can look for the fractional shortening. And then for diastolic dysfunction, this E by A and IVRT, they are little time consuming, and maybe we can discuss them in little bit more in the later class. What I will say is that in shock, whenever you do the LVO, just keep on monitoring it, and with the changes, like you start epinephrine here, then you look at the LVO, how much change it happened. Child is not improving, you increase the dose or you increase another inotrope, say milrinone, and then you see the change. So that is what is more important. Did I answer the thing?
Yeah, perfectly. Actually, this probably clarified a lot of things. I hope for the trainees also, because they, after understanding the basic principles, understanding how to handle the probe, but ultimately they will go bedside with a clinical mindset. This is my disease, and which view, and what are the findings. Very well explained, and all the things. I hope there's many things clarified. So what I will conclude with this one line here. Many times we hear from the lecture or from the discussions, I hear and I forgot. So, but I see by putting the probe, this is one beauty of the point of care. When I see something, there's a bolus fluid required in IVC collapse or IVC, there is a collapse, IVC diameter is low. I'm pushing fluid, and after immediately I'm checking with the 2D same point of care ultrasound, and I'm seeing the response. I started sildenafil IV or nitric oxide. I measured half an hour before, and within 30 minutes to 60 minutes, I can demonstrate the response to PPHN. So that's the beauty of point of care that I can see. So that second part, today partly addressed probably. I see and I remember. So when the learning process, I hear, I may forget, I see, I remember, but I do. As a trainee, if tomorrow you will practice and do, probably you understand better. You will understand the dynamics and understand better. So these three process, probably by this session we covered hearing and seeing partially, because so many beautiful videos and demonstrations are there, and that's probably will stimulate the students to do it, and you do yourself and see, then probably will completely understand how the importance life is something you can see, demonstrate, and exactly you will convince yourself for life. This is the utility of doing a point of care ultrasound, and particularly in cardiac assessment. Because other many places in neurosonogram, it's a preventive approach or the anatomical diagnosis, but by cardiac assessment, it is ongoing management. It is going to help you. It is not only the diagnostic, ongoing management. You will get help by a handy help. So I just will. This purpose of the session was we will discuss again some cardiac cases like PPH and other things still pending. But how you will use your diagnostic tools rightly, that's probably Dr. Naveen has very well highlighted all important scenarios, cardiac important scenarios, how to assess it. So hopefully this will help the trainees and students, and not many questions because of we used to get 22 questions normally, because that's the platform was different just 2 sessions before. The last 2 sessions, this platform changed, newly probably access issue or other issue, I'm not sure, but we got less questions today. But hopefully there was such a well presented talk with 45 minutes. I was surprised. I was a little wondering up mid of the session is going to finish by 50 minutes. Perfectly well covered and addressed all the issues hopefully. Thank you, Dr. Naveen, again.
Thank you.
Thank you. So we can close the session. Not more questions, but I hope that session is recorded. And the sessions, when recording session like this, where sometimes review and repetition help for the trainees, and this repeated talk will be loaded somewhere. And probably I will request, I request trainees, whenever there is some workshop of this point of care ultrasound about cardiac and neurosonogram and lungs ultrasound, 3 ultrasounds happening, probably please participate and see yourself and learn. That's I'll see. And probably Dr. Naveen cites some SCAN India sites also there, where you loaded a lot of training materials and teaching materials. They can also, trainees can review there. And this presentation also, when we upload it, they can review, because in one go, people may not understand completely. It's a training period, 1-year training period. Many things we have to learn there. But these are the sessions where it will stimulate you, it will make you aware how to use this particular skill in the best way. Okay. So anything in message, in some learning message you want to pass to the trainees, then we can probably close the session, Dr. Naveen.
Yeah. So I think as Dr. Nalini very, very rightly pointed out, that the first step is hearing, and then the second step is understanding, and the third step is doing. So this class was mainly about sensitizing you to the point of care sonogram. And even though the evidence doesn't suggest that it may be a magic, but it does help many a time when you are taking care of the baby once you start doing it. So I will urge you that this is now essentially, it is becoming the one of the, like it's like your stethoscope, right? If you have a probe and you can see what is happening, then that will definitely help the child. So start doing it, and start doing it from the scratch, even doing it from the apical 4-chamber view. Even that alone, single thing can give you a hell lot of information. So start doing it, and then there are many courses in the countries which are going on. And if you have the interest, you can enroll in those courses. So thank you, Nalini. Thank you again for inviting, and thank you for the wonderful session.
Thank you very much for your contribution for the continuous learning of the students. Thanking you, and thanking all the delegates and participants. So late night they participate, and they put questions and they interact, and they encourage us to go for coming back for the next session. Thanking all the delegates. Good night. Bye-bye. Thank you.
Good night. Bye. Bye. Thanks.